is April 1st, 2022. I'm Megan Crawford and I'm going to be doing my head to toe assessment. First, I'm going to scan the room. Okay, from the ceiling, floors. All right. Alright, I'm going to first start by doing an overall assessment of the skin. I see no discoloration. Skin is warm and dry to touch. I feel no edema. I see no lesions, no bruising, no scarring, no discoloration, no nevi. Skin turgor intact. Okay. Now I'm going to assess the head and the face. Head is normal cephalic in size and shape. It's midline in position. When I palpate, I feel no depressions. You feel any tenderness?
No.
Okay. No masses. I see no lesions, no infestations. Hair is evenly distributed on the scalp. It's brown and shiny in color. Now I'm going to palpate the TMJ and have the patient slowly open and close his mouth. Any tenderness?
No.
Okay. No tenderness. I felt no subluxation, no crepitus, no popping. Now I'm going to assess cranial nerve number 5. For sensory, I will have the patient close his eyes and tell me when he can feel light touch.
No. No.
Okay. Cranial nerve number 5 is intact. Now I'll assess cranial nerve number 7 for facial symmetry. I'll do so by having the patient smile, frown, puff out his cheeks, pucker his lips, and raise his eyebrows. Okay. Patient has facial symmetry, so cranial nerve number 7 is intact. Now I'm going to palpate the temporal arteries. Any tenderness?
No.
No tenderness or masses felt on palpation. Now I'm going to palpate the lymph nodes, preauricular, postauricular, occipital, tonsillar, anterior cervical, posterior cervical, submandibular, submental, and supraclavicular. Okay. Any tenderness?
No.
Okay. No masses, no tenderness felt on palpation. Now I'm going to assess the eyes. Eyes are symmetric on the face. The eyelashes grow outward and away from the eyes. Eyebrows curve out past the eyes. Looking at the left and right lower conjunctiva, they are pink and moist with no lacerations or discharge. Both upper conjunctiva are pink and moist with no lacerations or discharge. Sclera are white. I see no lesions present on inspection. Now I'm going to assess the internal structures of the eye. Looking in the left eye, I see the optic disc. I see the red reflex is present. The fundus has sharp margins, and I see no bulging. Okay. Right eye, I see the optic disc, red reflex is intact, fundus is not bulging, and the fundus margins are sharp. I'm going to assess cranial nerve number 2. I'm going to do pupillary response to light, starting with the left. Look forward for me. Okay. The left pupil constricts directly while the right constricts consensually. And then the right pupil constricts directly while the left constricts consensually. I'm going to further assess cranial nerve number 2, the optic nerve, by having the patient read from the Snellen eye chart one eye at a time and tell me what he can see without squinting. Okay. The patient has 20/20 vision in the left eye, and then with the right eye,
LT.
Okay. Patient has 20/20 vision in the right eye, and he normally wears corrective lenses. Now I'm going to assess cranial nerve number 3, oculomotor nerve. No, first I'm going to assess peripheral and central vision by having the patient look at my fingers, cover one eye at a time, starting with the right, and then tell me how many fingers I'm holding up.
2, 1, 1, 2,
Okay, then cover the left, tell me how many fingers I'm holding up.
2, 1, 1, 2.
Okay, central and peripheral vision are intact. Now I'm going to test cranial nerve number 3, oculomotor nerve now, by having the patient test his convergence and accommodation reflexes. So first I'm going to test accommodation, have the patient look at my finger, and then focus his eyes behind my finger, and then focus back on my finger, okay? Patient's eyes, his pupils constrict when he focuses back on my finger, so eyes are accommodating. Now I'll test convergence by again having the patient look at my finger, and then with your eyes only follow. As my finger gets closer, the patient's eyes cross and his pupils constrict, so his eyes converge. Now I'm going to test cranial nerves 3, 4, and 6. I will do that to test conjugate gaze with extraocular movement. So I'll have the patient follow my finger through these 6 motions with only his eyes. Okay, patient's conjugate gaze is intact, so cranial nerves number 3, 4, and 6 are intact. Now I will assess the ears. Ears are symmetric on the face. When I palpate the pinna and the tragus, you feel any tenderness?
No.
No tenderness or masses felt on palpation. Now I'm going to assess the inner structures of the eye. The auditory canal on the left, pulling up and back on the pinna, I see that the auditory canal is free of erythema, lesions, swelling, and exudate. The tympanic membrane is pearly gray in color. It is not bulging. I don't see any perforations. And then on the right, pulling up and back on the pinna, I see that the auditory canal is free of erythema, lesions, swelling, or exudate. Tympanic membrane is fairly gray in color. It's reflective. I see no perforations, no lesions. Now I'm going to assess cranial nerve number 8, the auditory nerve. I will do so by performing the whisper test. Have the patient cover one ear at a time and tell me what he can hear when I whisper 3 words to him. Okay, 1,
1, 2, 3.
okay. And then on the left.
1, 2, 3.
Okay, very good. Now I'll further assess cranial nerve number 8 using my tuning fork. I'll perform Weber's and Renee's test. Weber's test first. I'll strike the tuning fork and have the patient tell me if he can hear vibration on both sides equally. This is to test lateralization.
Yes.
Okay. And now I will test that air conduction is greater than bone conduction by performing Renee's test. I'll strike my tuning fork and have the patient tell me when he can no longer hear sound. Okay, tell me when.
Now.
And then now.
Now.
Okay. And then on the right, tell me when you can no longer hear the sound.
Now.
And then now. Okay. Air conduction is greater than bone conduction. Next, going to assess the nose. Nose is midline on the face. I see no deformities. It's straight. Now I'm going to assess the patient's cranial nerve number 1, the olfactory nerve, and nasal patency. I will hold a piece of gauze to his nose and he will inhale with one nostril at a time and tell me what he smells. And then first on the left, and then on the right. Okay, what did you smell?
Alcohol.
Okay, so patient's nasal patency is intact on both sides, and cranial nerve number 1, his sense of smell is intact. Now I'm going to palpate the maxillary sinuses, frontal sinuses. Okay, any tenderness?
No.
Okay, very good. Now I'm going, and I didn't feel any masses either. Now I'm going to assess the neck. It's straight. When I palpate the trachea, it's midline and straight in position. Any tenderness?
No.
Very good. I'm going to go on to assess the thyroid. I have the patient lean slightly forward and toward me and swallow. Okay. Thyroid goes up when patient swallows. I didn't feel any masses, no enlargement. And on this side, slightly forward and towards me, please, and then swallow. Okay, thyroid rises with swallowing. I did not feel any masses on that side or any enlargement, any tenderness.
No.
Good. Okay, now I'm going to palpate the carotid artery on the right, and then on the left. Pulses were 2+. Now I'm going to auscultate the carotid artery on both sides. When you feel my stethoscope, please hold your breath, please. And then on the right. Okay, no bruise auscultated. Now I'm going to assess the posterior chest wall. Have the patient turn this way for me. Okay. Looking at the chest wall, I see no deformities. It's symmetric. Not seeing any signs of respiratory distress. No accessory muscle breathing. I'm going to assess his chest wall symmetry of expansion by placing my hands on his lower back and then having him take a deep breath for me. Okay, chest expands symmetrically when the patient takes a breath, so his chest wall is symmetric. Now I'm going to percuss over the posterior chest wall. And then laterally. Okay, heard resonance overall, which is expected finding. Now I'm going to auscultate the posterior chest wall. And then when you feel my stethoscope, take a breath. And laterally. Okay, I heard no adventitious breath sounds. Breath sounds are clear and equal on auscultation. Now I'm going to assess for evidence of consolidation by performing ephogeny, bronchophony, and whisper pectoriloquy, starting with bronchophony. When you feel my stethoscope, please say 99.
99. 99. 99. 99.
Very good. And then when you feel my stethoscope, please say quietly the word 99. Okay. And then when you feel my stethoscope, please say the letter E.
E.
Okay. Now I'm going to assess for tactile firmness symmetrically. When you feel my hand, please say the word 99.
99.
Okay. Tactile firmness is done posteriorly. Now I have the patient turn forward for me. Assessing the interior chest wall. I see that it is symmetric. There are no obvious deformities. Patient has no signs of respiratory distress, no accessory muscle breathing. I'm going to assess for anterior tactile firmness. So when you feel my hand, please say 99. Okay, very good. Now I'm going to auscultate the anterior chest wall. You feel my stethoscope, take a breath for me. Okay, very good. Breath sounds are clear and equal, no adventitious breath sounds. Now I'm going to assess the cardiovascular system. I'm going to have the patient sit here, and when I'm going to listen with first my diaphragm and then with my bell, starting with the aortic valve, pulmonic, Erb's point, tricuspid, mitral, okay, and then with my bell. Okay. I heard S1 and S2 sounds, no extra heart sounds, no murmurs and no gallops. Now I'm going to locate the point of maximal impulse. It's on the left sternal border midclavicular line, fifth intercostal space. And I'm gonna listen for the apical pulse for a full minute. Okay, heart rate is 65 beats a minute, normal sinus rhythm. Now the patient lie down for me, please. I am assessing the chest wall. I'm seeing no heaves or lifts. On palpation, I'm not feeling any thrills when I palpate over the auscultation points. Not seeing any JVD. And I'm going to listen one more time while the patient is lying supine. Still only hearing S1 and S2 sounds with no extra heart sounds, no murmurs or gallops. Now I'm assessing the abdominal wall. I'm seeing that it's symmetric with slightly rounded contour. Listening to the abdominal aorta for bruits and the renal arteries, iliac arteries, femoral arteries. No bruits auscultated, so I'm going to go on to auscultate the 4 abdominal quadrants, starting with right lower. Okay, I hear normal active vowel sounds. Now I'm going to percuss, starting with right lower. Okay, I hear tympani with the exception of dullness over his liver and his spleen. Now I'm going to palpate, starting with light palpation and then deep palpation. Okay, any tenderness?
No.
Okay, no tenderness or mass is felt on palpation. I'm gonna palpate the liver, any tenderness?
No.
Okay, and then the spleen, I'm not feeling it, but that is a normal finding. So now I'm gonna have the patient sit up for me, please. Just sit straight up. Oh, no, stay this way. And then I'm gonna palpate for CVA tenderness. Is it tender?
No.
No tenderness. Okay, and now turn this way for me. Now I'm going to assess the musculoskeletal system. I'm going to palpate the joints, shoulders, elbows, wrists, fingers, knees, the ankles and toes. Any tenderness?
No.
Okay, very good. Didn't feel any masses, no swelling, didn't see any redness, no crepitus, and everything is symmetric. So now I'm going to go on to assess range of motion. I'm going to start with the fingers, follow my lead, flexion, extension, hyperextension, abduction, adduction, radial deviation, ulnar deviation. Very good. That was the wrist. And then with the wrist, we'll do flexion, extension, hyperextension, rotation. We're also going to assess thumb opposition by doing this. Very good. Okay, now we're going to do range of motion of the elbows, flexion, extension, hyperextension. Very good. Shoulders, we'll do flexion, extension, hyperextension, in adduction, and then abduction, internal rotation, external rotation, circumduction. Very good. With the knees, flexion, extension, hyperextension. Very good. Ankles, plantar flexion, dorsiflexion, rotation. Good. With toes, flexion, extension, hyperextension, abduction, adduction, and then with the ankles we'll do inversion, so in, and then eversion, out. Very good. We will do now, I will assess the capillary refill in the fingers, less than 3 seconds, radial pulse on the right, radial pulse on the left, both 2+. Dorsalis pedis pulse on the right is 2+, dorsalis pedis pulse on the left is 2+. Now I'm going to do deep tendon reflexes. We're going to do brachioradial on the right. Very good. And then on the left. And then bicep on the left. And then on the right. Very good. and then tricep on the left, and then tricep on the right. Very good. Plantar on the left, patellar on the left, patellar on the right. Good. Achilles left, Achilles right, Babinski reflex on the left, Babinski reflex on the right. Very good. Now we'll do strengths. We'll do grip strengths. 5 pluses. Very good. On the hands, on the elbows. Do this, please, and then pull against, and then push me away. Very good. Left and right elbows are 5. Shoulder shrugs. Push up against my hands. Left and right shoulder, both 5 plus. Abduction, so push up against my hands, and then pull down. Very good. On the left and the right, shoulder strengths are 5. We'll do knee strengths, pull, and then push. On the left, pull, push. On the right, 5 on left and right. We'll do dorsal reflex on the left, and then plantar on the left, 5 plus. Dorsal flex on the right is 5, and then plantar on the right is 5. Stand for me, please. Now we're gonna do range of motion of hips, flexion, extension, hyperextension. Very good. And then on the left, we'll do flexion, extension, hyperextension, inversion, internal rotation, external rotation. Okay, and then on the right, internal rotation, external rotation, and then circumduction on the right, circumduction on the left. Very good. We'll do hip strengths. So push your leg out against my hand on this side. Left, that's a 5. Then on the right, a 5. We'll do cervical spine range of motion. So flexion, extension, hyperextension. Very good. Rotation. Okay. Lateral flexion this way against my hand. Okay. That's intact, and it's a 5 plus strength. And then this way, and on the right, it's a 5. And now we'll do the lumbar spine. So please turn away. Thank you. So I see no deformities. I feel, do you feel any pain or tenderness here?
No.
Very good. Curvature is S-shaped, not seeing any evidence of scoliosis or irregular curvature of the spine. Lean forward for me just a little so I can further inspect. Very good. Okay, now we'll do range of motion of the lumbar spine. Lean forward for me, that's flexion. Straight up and down is extension, hyperextension, and then we'll do lateral deviation. So, lateral flexion to the left, lateral flexion to the right. Very good. And then rotation, just kind of, there you go, pivot. Very good. Now we'll do Romberg's test. Have the patient face forward for me, please. They'll come this way. Like face forward. There you go. And then arms out, eyes closed, feet together and stand. Very good. That's Romberg's test. You can open your eyes. Now we'll do walking and just regular walk toward me. Very good. And then turn and walk away in tandem, heel to toe. Very good. And then come back to me, and then I need you to hop on your left foot, and then hop on your right foot. Very good. And then we'll test cerebellar reflexes. We'll do serial finger touches. There you go. And then with your right finger, touch to mine. Okay, and then with your left, touch to mine. Okay, and then we'll do the hand flap. So take your right hand, there you go. And then with the left hand, do the same. Okay, and that is my head to toe assessment.